When a patient's metabolic panel returns a critical low for serum sodium, it triggers an immediate clinical alert. This low sodium reading identifies a specific biochemical state, one that serves as a symptom of a broader physiological disruption. That low number on the lab report reflects a physical imbalance between the total amount of sodium and the total volume of body water. Treating the concentration in isolation ignores the mechanism that created the deficit, leading to interventions that are often at odds with the patient's actual volume status. The common clinical reflex is to address the low sodium by simply administering a 0.9% sodium chloride saline drip. Administering 0.9% saline is strictly an asymptomatic treatment. It temporarily bridges the gap by providing a baseline concentration of sodium, but it corrects nothing structural. Definitive care requires uncovering the specific volume defect that forced the sodium concentration to drop in the first place. We establish this through a core diagnostic framework. This 3-branch flowchart categorizes the patient into 3 distinct fluid statuses: hypovolemic, meaning they are dry; euvolemic, meaning normal fluid volume; or hypervolemic, meaning they are wet and retaining excess fluid. The correct intervention for hyponatremia is entirely dictated by which of these 3 volume branches the patient occupies. The first branch of our algorithm isolates hypovolemic hyponatremia. Hypovolemia is a state where the patient is severely volume depleted. They are physically dry. If we visualize the internal vascular space as a beaker, we see a depleted waterline with sparse sodium particles. Both elements are low. This state is often driven by iatrogenic, or a medication-induced, fluid loss. The primary drivers of this medical fluid loss are diuretics, specifically Lasix and thiazides, which force the kidneys to excrete volume. The second category is gastrointestinal fluid loss. Severe bouts of nausea, vomiting, and diarrhea rapidly drain the body's volume reserves. The third category involves internal fluid losses. Conditions like pancreatitis trap fluid outside the vascular system in a process called third spacing, effectively leaving the active circulatory system dry. Finally, we must check for endocrine causes. Primary adrenal insufficiency, classically known as Addison's disease, prevents the retention of sodium and water. The clinical heuristic to memorize here is simple: Addison's makes you dry. Because the patient is functionally dry across all these etiologies, the treatment logic is straightforward. You restore the balance by administering intravenous fluids. In hypovolemia, you correct the sodium imbalance by directly reversing the volume depletion. The middle branch of the algorithm covers euvolemic hyponatremia. Euvolemia is a state where total body volume appears relatively normal, but the existing sodium is heavily diluted by the retention of free water. Returning to our vascular beaker model, the overall fluid sits at a normal baseline level, but the sodium particles are spread too far apart. The dominant driver of this diluted state is the syndrome of inappropriate antidiuretic hormone, or SIADH. SIADH triggers the continuous release of ADH, forcing the kidneys to reabsorb free water back into the bloodstream instead of excreting it. A critical trigger for SIADH is lung cancer, specifically adenocarcinoma, which can ectopically secrete ADH. Exogenous sources, such as prescription drugs containing ADH, also artificially create this water-retaining euvolemic state. Systemic endocrine disruptions, notably hypothyroidism, also reduce free water clearance, leading to similar dilution. The final cause in this branch is behavioral, psychological polydipsia, or obsessive water drinking. A massive, continuous intake of water dilutes the body's sodium stores faster than they can be managed. Yet polydipsia does not cause hypervolemia. Normal, frequent urination compensates for the extreme volume intake, keeping the patient technically euvolemic, while still dangerously diluting their sodium. The treatment logic for the euvolemic branch requires strict discipline. Because all of these etiologies result in a free water retention problem, infusing additional fluids would dilute the sodium even further, compounding the crisis. The definitive treatment here is strict fluid restriction. In euvolemia, you cannot fix the low sodium by adding salt. You fix it by withholding free water. The final branch addresses hypervolemic hyponatremia. This is a state of severe fluid overload. The patient is edematous, or physically wet. In this version of the vascular beaker, fluid is actively overflowing. the sodium particles are hopelessly diluted by a massive expansion of volume. Total body sodium might actually be elevated, but the immense increase in total body water severely dilutes the concentration. This extreme fluid overload is almost always driven by major organ failure, causing systemic edema. Heart failure compromises cardiac output, leading to fluid backup in the lungs and extremities. Liver failure decreases albumin production, causing fluid to leak into the interstitial spaces, and renal failure in the body. Reversing this state requires an aggressive shift in volume management. Because the patient is already edematous, fluid must be actively extracted from the vascular system. The treatment is to administer loop diuretics, like Lasix, to offload the excess fluid. For hypervolemic patients, forcing the kidneys to excrete the excess water is the only effective method to reconcentrate the body's sodium. Looking at the complete three-branch flowchart, the logic of volume stratification is clear. The algorithm dictates an inverse therapeutic relationship. Dry patients receive fluids, normal volume patients get fluid restricted, and wet patients are aggressively diuresed. Administering 0.9% sodium chloride remains a valid initial step for asymptomatic patients, but it never replaces this targeted volume management. In clinical practice, a history of lung malignancy or brain disease significantly narrows the diagnostic field, as these conditions are primary drivers of the euvolemic pathway. In these specific pathology presentations, SIADH is almost certainly the underlying mechanism. Mastering hyponatremia requires looking past the lab value. You must evaluate the physical fluid status, categorize the volume defect, and treat the structural failure beneath the numbers.